our mission this time is to decode a really massive source document all about medical coding.
Yeah, it is a dense one for sure.
Right. And you might picture translation as, I don't know, diplomats at the UN, but clinical translators are turning doctors' notes into these alphanumeric codes, and that actually dictates the flow of trillions of dollars in the U.S. healthcare system.
Absolutely. It is, the lifeblood of the whole industry.
Okay, so let us unpack this, because if a medical coder misinterprets a physician's note, it does not just cause a typo in your chart, right? I mean, it can trigger federal investigations or even bankrupt facilities.
Well, yeah, the stakes are just incredibly high here, mostly because this coding language fundamentally changes how doctors get paid now.
Wait, how so?
Well, for decades, healthcare was just a simple menu. You get an X-ray, the hospital bills for an X-ray. It was just fee for service.
Right, just traditional billing.
Exactly.
Yeah.
But now, the industry is shifting hard to what is called value-based care.
Wait, so if they aren't paying per service anymore, how exactly do they get paid? Do doctors just get like a flat salary per patient?
Basically, yes. It relies on a capitated payment. So the facility receives a fixed monthly lump sum to manage a patient's overall health, regardless of how many times they actually visit.
Oh, wow. Okay.
But to calculate that lump sum fairly, they use what is called hierarchical condition category coding, or HCC. And that generates a risk adjustment factor, which is also called a RAF score, that maps out your total disease burden.
Let me make sure I get this. So if I have, say, basic diabetes and also a really severe diabetic complication, do the coders just bill for both to, increase my RAF score and get a bigger monthly check?
Actually, no. That is where the hierarchical part kicks in. A severe code completely subsumes the basic one.
Oh, I see.
Yeah. So the system recognizes the complexity without double counting. And here's the mechanism that really drives the whole industry. Those RAF scores, they reset to zero every single calendar year.
Wait, every single year? So if the coders fail to aggressively recode those chronic conditions annually, a highly complex patient just looks perfectly healthy on paper.
Exactly. And then the hospital does not get the funding they need, which, ultimately means fewer resources for your actual care as a patient.
Which brings up that massive financial temptation that we kind of alluded to earlier. I mean, if coders define a patient's holistic disease burden, some facilities might try to artificially inflate that burden to get more money, right?
Right. And that is where, you run into serious legal trouble.
Yeah, because I saw the term unbundling in the sources regarding that kind of inflation, but I did not quite grasp how it works in practice.
Unbundling is essentially breaking down a single comprehensive procedure into its individual parts, and then you bill for each separately just to increase the total payout.
Can you give an example of that?
Sure. Think of it like a restaurant charging a customer separately for, the bun, the patty, and the lettuce, instead of just charging you for the whole burger.
Ah, okay, that is a really great way to picture it. And the government polices this aggressively, right? Because upcoding and unbundling drain taxpayer-funded Medicare pools.
Oh, absolutely. They treat a deliberate medical typo as basically equivalent to stealing from a federal vault. Under the False Claims Act, the penalties hit nearly $28,000 per individual false claim submitted.
Wait, per claim? That is insane.
Yeah, plus triple the financial damages sustained by the government. And for really severe fraud, perpetrators can face up to 10 years in federal prisons.
10 years. So you have these massive federal penalties for getting it wrong, which implies this work requires intense, over-the-shoulder oversight. Yet paradoxically, something like 60% of these coders are doing this high-stakes translation from their spare bedrooms.
Right, but because of IMA privacy rules, that home office has to basically mimic a highly secure hospital basement.
What does that actually look like for a remote worker?
Well, remote coders cannot just connect to their home Wi-Fi and start working. They must use virtual private networks. They have to ditch factory default router passwords and physically install privacy filters on their monitors.
Wow, really?
Yeah, so even their own family members cannot see patient data.
Imagine having to tell your spouse they don't have the security clearance to look at your laptop screen. But, okay, if this work is entirely digital now, how are algorithms slipping in? The sources mention natural language processing and machine learning.
Well, those technologies are really changing the landscape by actually reading clinical notes for context, not just doing simple keyword searches. They analyze the phrasing to understand if a condition is current, historical, or just, suspected.
So are the machines, completely taking over the coding jobs then?
Not at all, actually. They lack the clinical reasoning for highly complex, multi-morbid cases. So human coders are basically evolving into AI validators, managing all the intricate exceptions the software fails to grasp.
Got it. So they are essentially auditing the machines, and they will definitely need that tech because the foundational code system itself is about to get a massive digital upgrade, right? With the ICD-11 rollout coming to the U.S. between 2025 and 2027.
Right, we are moving to a digital-first architecture with over 6.3 million searchable code combinations.
6 million.
Yeah, the system is designed for extreme specificity. You can code not just that a patient was bitten by an animal, but the specific species and the exact location on the body where it happened.
6.3 million codes is just staggering. Here is where it gets really interesting, though, and I want to leave you with a thought to mull over.
Oh, I love these.
If natural language processing becomes advanced enough to instantly translate a doctor's conversational words into one of 6.3 million specific codes, could these predictive algorithms eventually start suggesting diagnoses to the physician before the patient encounter even ends?
Oh, wow.
Right. It would completely reverse the traditional coder-provider relationship. The translator might just start writing the script.